live and recording with Dr. Philip Ovadia, the iFix Hearts and Ovadia Health. Do I have that right, Doctor?
Yeah, Ovadia Heart Health. And great to be here with you, Rob.
Well, I've been watching your stuff for a while, and I was really excited when we got a chance to meet down in Costa Rica and learn more about your story on heart health and how metabolic health is so critical, and carnivore or whatever nutritional expertise you're going to share with us today. But welcome, and maybe you could tell us a little about yourself, where you're at, and what got you into this crazy business of nutrition and changing lifestyle.
I know, the crazy business of doctors trying to educate people about what to eat. It really does sound insane. And honestly, it would have sounded insane to me up until, about 7 or 8 years ago when I had my eyes open. And, really that started with my own personal journey. I had struggled with obesity since childhood, and got to a point where I was pre-diabetic and morbidly obese. And at that, I had been a heart surgeon for over a decade. And here I was, taking care of patients with heart disease and realizing that I was going to end up on my own operating table, so to speak. I was following the same path that so many of my patients had followed. I have a family history of heart disease. So I was concerned, but I was at a loss because I was following the advice, that we learned to give patients, that we were educated to give our patients. Eat less, move more, eat a low-fat diet, eat according to the, food pyramid, all of that. And it wasn't working for me, and it wasn't working for my patients. And thankfully, I started to get exposed to some different information. I started to ask some different questions, which I think is very important. And ultimately, I learned about low carbohydrate approaches, the problems with sugar, the problems with processed food. And, by adopting a low carbohydrate diet at first, and then, more of a ketogenic diet, and ultimately evolving to a carnivore diet, I was able to fix myself first. Lost over 100 pounds, have maintained that weight loss, reversed the pre-diabetes. And, today at 48, I can say I'm in better shape than I was when I was 18 in high school.
Wow.
So,
wow.
Yeah. And, that really opened my eyes. I started asking, why didn't I learn about this in medical school? Why don't my colleagues talk about this? Why isn't this discussed at the conferences? And I came to realize that, the disease that I had focused my career on, heart disease, we have gotten it wrong.
Mm-hmm.
We've been treating it wrong. We misunderstand what causes it. And therefore, we really have no chance of meaningfully impacting it and meaningfully improving it if we don't even understand what's causing it in the first place. And so, that has led me to my efforts over the past few years to educate my patients and educate those who will be my patients how not to become my patients, how to stay off my operating table. That's the title of my book that I, came out over a year ago. And that's really my mission now, to keep as many people off of my operating table as possible.
Well, your book is really fascinating. I actually started reading it earlier, and one of the things that inspired me, similarities for both of us, because Gary Taubes was one of the people that sort of turned my brain around, and I know that you had mentioned that also. And as you dove more into this, did your brain sort of first say, well, this can't be? And how did you find the way to kind of get yourself inspired in it first, as maybe we can help others find this inspiration also?
Yeah. So, like I said, it really did, start as what do I have to lose? I heard Gary talk, and I read his books, and, I did some research, And, it really was, what do I have to lose? What I've been doing has not been working. So let me give this a try. And I tried it and it worked. And, and then I started asking, well, why did this work for me? Has it worked for other people? And you get out there and you discover that it's worked for many, many people, and that it really was the default, for much of our evolutionary history. And it's only recently that we started doing something else. And you kind of flip the script, because, you go into this thinking you're running this experiment by trying this new diet. And you realize that this is what we have been doing as human beings for the vast majority of our existence. And really, the experiment in the new diet is, the Western diet, the standard American diet, the processed food that we eat so much of today. So that was part of it. On the professional level, really, I had to think back to medical school, and I thought about, that quip that we hear over and over during medical school, that half of what you learn during medical school is going to be proven to be wrong by the time you retire. We just don't know which half. And what I came to realize is that this falls into that bucket. The way that we have been approaching heart disease, most chronic disease, I would say, obesity, diabetes, it's in the half that is wrong. And we're in the process, I would say, of discovering that, or you could say rediscovering that, because again, this is stuff that we knew and forgot. It's not stuff that we have to prove again.
It's interesting. I was in the operating room today. I had a third-year medical student and a first-year OBGYN resident operating with me, and it's interesting how you talk about these ideas about metabolic health, and that maybe things like keto and carnivore are something people should think about and cause disease. And they were completely sort of turned off by the story and not open to something that is so opposite. What are your thoughts on that, and how we can maybe make some changes? Because it seems to me we're all so resistant. And when doctors are resistant and medical students are resistant to new and different ideas, how do we change?
Yeah, no, I think it's a very dangerous trend in medicine. Doctors are supposed to be curious. You think about some of the amazing innovations that have been made. I oftentimes read about the history of heart surgery, and you go back and you realize what some of these innovators did. And they were told there is no way this is ever going to work. There is no way you can operate on the human heart. It was like absolute no-go land. And yet a few curious and brave, physicians started doing it, and they did the research, and they, proved it worked. And now, of course, it is commonplace and life-saving. And if we're not able to ask these questions and, question these dogmas, how do we move forward in medicine? Because the medical history books are littered with examples of things that were accepted as absolute truth that were later figured out to be completely false. And if you can't question which of those truths might be false, there's no way for us to move forward in medicine.
Do you think we actually know the cause of heart disease?
I think we do. I think, it was fairly definitively proven. You go back to the literature in the 1970s, 1980s, you go to the work of Gerald Reaven and others, and it is exceedingly obvious that, heart disease starts with damage to the blood vessels. I think, that would be hard to argue with that statement. And there are only a few things that really end up damaging the blood vessels commonly. We have things like smoking, toxins that are directly damaging to the blood vessels. And we have insulin resistance and, the many downstream effects of the insulin resistance that end up leading to blood vessel damage. We have inflammation that comes from other places, things like infections. But we really have to start with the damage to the blood vessel wall as the root cause of heart disease. And if we're going to make a meaningful impact, we have to be addressing that root cause. And unfortunately, the vast majority of our efforts today don't address that root cause. They look at downstream, downstream in the process, and things like cholesterol, which is not the root cause. It is a downstream part of the process, and therefore trying to target that is going to be largely ineffective.
So we work to reduce sugars and reduce fats as the cause, essentially, and our healthy diet, which is either a pyramid or my plate. And I'm just curious, kind of what your thoughts on that and how you led to the change. Because ultimately, fruit, fiber, vegetable, seeds, nuts, lean meat, and healthy fats, which healthy fats tend to be seed and nut fats and avocado. And maybe you could kind of lead in with your thoughts on all of that and what changes you've been thinking about and sharing in your health advice.
Yeah. So the first thing, I do is I look at the macro evidence there. And so we have been, advocating that style of eating here in the US, since 1980. So 40 plus years that has been the advice. When you look at the macro trends of the food that gets eaten here in the United States, it has shifted in accordance with those trends. We eat less animal fats. We eat less, fats in general. And our health has gotten worse. So that causes me and anyone else that is thinking about this logically to at least step back and say, what's going on here? Of course, that's not, proving causation, but it's got to get you to ask the questions. And then, like I said, I look back at our evolutionary history. What we have been eating as human beings for the millions of years that we have been on this planet. And it is primarily animal products and animal fats, animal protein and animal fats, I should say. And so again, it almost becomes hard to conceive of how we started, thinking that way in the first place, that the standard American diet, that the food pyramid was going to be the answer, because, it just goes against our entire evolutionary history. And it really never made sense in the first place. And that's the point that I've come to, I would say, at this point. I'm tired of arguing, trying to prove that the standard American diet, that the food pyramid is a bad thing, because we never proved it was a good thing in the first place. So it's kind of it's a senseless argument for me at this point.
What does your plate look like, or your pyramid look like?
Yeah, so my plate, I guess it would be hard to fashion it into a pyramid, because it really has, two components to it. It has animal proteins and animal fats, essentially. That makes up over 95% of my diet, with maybe an occasional something else. But it comes down to animal protein, animal fat. I find that, prioritizing protein works well for me. So, my goal when I'm eating for a day is basically get enough protein in, have the fat that comes with it. I don't really worry about, the composition or how much of that fat there is. It's just kind of the fat that comes with it. And that's how I construct my diet on a day-to-day basis.
Is red meat the cause of disease or cancer, do you think?
Yeah, no, absolutely not. It is not the cause of heart disease. It is not the cause of cancer. It is not the cause of diabetes. It is not the cause of obesity. And again, it never was. So we don't have to prove that it isn't. The only science that you can find that, comes to that conclusion is very poorly done epidemiologic studies. And all the other studies that have looked at it do not come to that conclusion. And it's just, honestly, at this point, it's marketing. It is not science. It borders between religion and marketing for us on a societal level, for the healthcare system to still be believing that.
So we should recognize that it's wrong, and we're sharing ideas that red meat and animal products are really healthy for us. Do you have any other particular saying on ruminants or versus non-ruminants, or organic versus non-organic, or grass-fed or grain-fed? And what are your thoughts?
Yeah, so I would say I eat mostly ruminants. I eat seafood as well. I eat some non-ruminants, pork, and rarely rarely poultry, I would say. I believe that yes, grass-fed, regeneratively raised beef is the best way that we can eat on every level. I also recognize that that might not be obtainable for everyone. So I would rather you start with whatever animal protein you can obtain and you can afford, rather than eating the processed food, and the alternatives. I'd rather you start where you can start. But ideal, and I thankfully can obtain the good stuff, so to speak. But we have to realize the delta between bad meat, bad meat, conventionally raised meat, whatever you want to call it, and good meat is a lot smaller between the delta. A lot smaller than the delta between meat in general and processed food. So start with the animal protein that's accessible to you, that you can afford and you can obtain, and you're going to improve.
Chicken, turkey, fish, all these things are okay.
I think so. Again, are they ideal? I would much rather have, like I said, regeneratively raised or grass-fed beef than chicken or turkey. Non-ruminant animals are going to be, the quality of the non-ruminant animal meat is going to be more dependent on the food they're eating than with ruminants. Ruminants truly are magical animals. You can feed them grains and corn, and they can turn it into saturated fat, something that humans can't do. So again, you're going to have smaller differences in your ruminant animals dependent on what they're eating versus your non-ruminant animals. So if I'm eating non-ruminant animals, I'm more careful about how I'm sourcing it, where I'm getting it from, and more concerned about what that pig ate or what that chicken ate.
Do eggs cause hypertension?
Absolutely not. And again, just illogical, how we would ever come to that conclusion. And the science just simply doesn't support it, and it's always kind of entertaining on some level to follow the science behind eggs, because we all know, the flip-flops that it does. And this study shows they're good. This study shows they're bad. This study shows they're good. But again, when you really drill into the well-done studies, there is no reason to be concerned about eating eggs.
When you talk to your clients, your patients, your community, is carnivore versus keto important, and how do you address that? And some people eat some plants and some carbs versus, where do you, if you eat a little bit of carbs, is that the end of the world? Or how do you help people sort of live a life in normality, but do something special like you're sharing?
Yeah. So, ultimately it really comes down to where that person is starting from, and what they're trying to solve for. For many people who, are just trying to improve their overall health, trying to lose weight, a ketogenic type diet is going to be okay. And again, I do ask people to think about what that means. You can't be buying the junk food that's labeled keto, the processed food that's labeled keto, and thinking that that's going to be much better for you than than the non-keto processed food. But if you're eating whole, real food, first and foremost, I think the kind of distribution between how much carbohydrate you have in that, how much vegetables and carbohydrates you have, really depends on your situation. If you are metabolically broken, if you are not metabolically healthy, you cannot tolerate carbohydrates. And the more carbohydrates you have in any form, vegetables, or processed, uh, your body is going to have a tough time handling that. Um, and I guess the second part of that for people to understand is that most people are metabolically broken. We have the statistics. 88% of the adults in the United States do not meet all 5 measures of optimal metabolic health. So you have to be honest with yourself about that. Now, if you're metabolically healthy and you're active, do I think some non-processed carbohydrates are going to be damaging to you? No, I don't think they are. And if you want them, you can have them, but also realize that they're not any benefit. They're not essential. This is the other thing that I end up discussing with people. We can get all of the nutrients that we need from eating animal products. So fruits, vegetables, these things are not essential to the human diet. Fiber is not essential to the human diet. And so then you just have to ask yourself, what am I trying to accomplish? How is it serving me by eating these foods? And if you're being intentional and you're thinking about it and you're, paying attention to it, then I don't have a problem with that approach.
So, as you said, carbohydrates, plants are not required in our diet. They're not necessary. There's no health benefit from them. And fiber is also one of those things that are not good or healthy for us. And so essentially what you're saying is all of the plant products have some toxicity that can lead to disease like heart disease and cancer and all the other diseases in humanity.
Yeah, I think, we do see, especially in certain people, and for instance, autoimmune type diseases, these are clearly triggered, by plant products. So if you have an autoimmune disease, you have to be very careful. Like I said, if you are metabolically healthy and you're, eating some vegetables with your primarily animal protein based diet, do I think that's going to cause you heart disease or cancer? Probably not, is my guess. But, again, why, what is the benefit that you're getting from that? And the answer is there is no real benefit. So I personally don't choose to eat it. Do I suffer any ill effects when I eat the occasional, vegetable or fruit? No, I don't. Nothing obvious. But again, it just doesn't benefit me ultimately. So for the most part, I avoid it.
So how do you approach your clients? How open are they? They show up with whatever diseases, and mostly cardiovascular diseases, hypertension, I imagine. And you lead in with carnivore, or how do you approach them and sort of get them to listen to an idea and then move forward in a slow manner, fast manner, or just dive in?
Yeah, that's, I would say, kind of personality dependent. Some people really want the, what's the final answer and how do I get there quickest? And they're willing to make the changes. And they're, you first have to have the discussion with them. You have to, help them to unlearn what they've heard their entire lives. And I'm fortunate that most of the people that find me and choose to work with me have already started down that path. But on the other side of things, I am still a practicing heart surgeon, and so I do heart surgery on people who, they just end up in the hospital with heart disease, or they end up in my office with heart disease. And these concepts are brand new to them. They haven't heard it before. And again, it goes opposite typically what they have been hearing from their other doctors. And really, the conversation there starts with, you've been following your doctor's advice, you've been following society's advice, and this is where you ended up, on my operating table. So do you think it, would make sense to at least consider a different approach? And many of them are very open to it. The unfortunate thing I run into is that, the patient will be open to it. They'll even start implementing the changes. They'll see good effects from it. And then one of their other doctors will tell them, you can't do that, it's killing you. And so we get into that, conflict ultimately. But I am quite confident recommending it at this point. I do recommend it to my patients who, who I do heart surgery on. And, again, all of those patients that end up on my table with coronary artery disease, they are all metabolically broken. I am yet to see a patient who is in perfect metabolic health, outside of the smokers, and that may be a whole separate thing. But, a non-smoker who is metabolically healthy does not end up getting heart surgery.
So silently sick, I call it. And you said the majority of people are metabolically unhealthy. How do they know it?
Well, hopefully they're going to have an insightful physician, an insightful practitioner of some sort that can point it out to them. But for themselves, what I really ask them to consider is, how do you feel on a day-to-day basis? And if you don't feel, optimally, if you're tired, if your gut is, bloated and inflamed, and you're, every time you eat, you're having digestive problems. If your joints are hurting you, these are the signs that you're not metabolically healthy. And the unfortunate thing in our society today is we accept these things to be normal. They have become so common that we accept them as normal. And again, I think this is a big failing of our medical system, because these things are not normal. They can be improved, and in many cases, they can be completely reversed. And again, the answer is look at the food that you're eating. So, on the large scale, I mean, what I would like to get people to do first and foremost is just acknowledge that what we are eating is the primary determinant of our health. And let's just start paying attention to that. We can have the argument later about, should I be vegan? Should I be carnivore? Should I be keto? But let's just acknowledge what we're eating is affecting our health, and let's start paying attention to what we're eating.
Is it true that the first sign of heart disease for many people is sudden death?
Yeah. So, a little bit older data, but basically, 50%, it's probably a little bit lower today. Let's say it's 30 to 40% of heart attacks, of first heart attacks are fatal. And, for, again, probably 60% ish, let's say, of people, their first sign of heart disease is going to be a heart attack. So it's not quite, majority that, the first sign is sudden death. Also realize that those statistics are a little bit hard to gather because, oftentimes people who just die, oftentimes we don't figure out why they die. So was it heart disease? Was it not? We don't do autopsies as much as we used to. So it's a little hard to really figure out the statistics on that. But sudden death is a very common presentation of, very common first presentation of heart disease.
So for many diseases, that first time event that tells you got cancer or heart disease that's serious and you are healthy before that. And I see in the fertility world, many people come to me and they're healthy, but they're infertile. And my suspicion is, well, infertility is just another disease, an inflammatory disease. And it's actually the number one thing that we all should be happening without difficulty. And so it's kind of like the canary in the coal mine. in the coal mine. And so what things can we do on the diagnostic side to help people identify if they're metabolically ill? And the other part to that is, the other part, just I'll ask this again potentially, because before I forget it. Are we good at predicting people's diseases in standard preventive medicine?
Yeah, that's a great question, and one we should be asking more. So, the second part is probably the easier one to answer. And that is, no, we are very lousy at diagnosing things early and, taking preventative measures. How can we do a better job of it? First of all, like you said, I think there are many canaries in the coal mine, things like infertility, things like inflammation in general, should alert us that there is a underlying problem to that. And all too often, when things present early on, we just want to cover up the symptoms. I look at high blood pressure. And, people are being diagnosed with high blood pressure earlier and earlier in life, the statistics show. We now have teenagers being diagnosed with high blood pressure. And we just say, oh, it's high blood pressure. We have medications for that. Don't worry about it. Take your medication, control your blood pressure. So it lowers the number. The blood pressure is controlled, but it's not addressing the underlying problem. And the underlying problem, when we look specifically at high blood pressure, in the vast majority of cases, is insulin resistance. It's really so interesting to me at this point. High blood pressure is one of the diagnostic criteria of the metabolic syndrome. It's one of the 5 criteria we look at. And yet most physicians, when they newly diagnose someone with high blood pressure, they don't figure out, do they have a metabolic problem? Do they have, the metabolic syndrome? Are they insulin resistant? There's such a disconnect there. So, what are some early, easy things that people can be doing and should be paying attention to? First of all, at home, you can measure your waist circumference. Waist circumference, again, one of the 5 diagnostic criteria for the metabolic syndrome. And it's actually been shown to be the most predictive one. So, get a tape measure, just above the level of your belly button. Best to do it first thing in the morning. And, if you're a man, you want that to be less than 40 inches. If you're a woman, you want it to be less than 35 inches. And those are very generous cutoffs, I'll say. I advocate for people to have a little bit of a stricter criteria there. But even going by those, you can pay attention to that at home because that's going to be one of the early signs. Again, if you have high blood pressure, if you have high blood glucose, pay attention to that because those are signs of metabolic disease. And then finally, the other thing that's so frustrating to me is, we have had all of this focus on cholesterol. And so everyone gets their cholesterol levels checked these days. And we don't pay attention to the right numbers. We are fixated on the LDL cholesterol. And for the most part, we ignore the HDL cholesterol and the triglycerides. And those 2 numbers are both, again, HDL cholesterol, triglycerides are the other 2 measurements of metabolic health. And they're both more predictive of heart disease than LDL cholesterol is. So again, if you have a high triglyceride level and you have a low HDL cholesterol level, both of those are more predictive of heart disease risk than having an elevated LDL cholesterol. And yet we spend all of our time focusing on the LDL cholesterol. So those are some things that, people should be paying attention to, and you should start paying attention to these things early in life.
So the 5 criteria of metabolic disease, waist circumference, greater than 40 in men and 35 in women,
Yep.
Hypertension,
Yep.
Elevated glucose levels,
Yep.
hemoglobin A1C fall into that at all? Is that
Yeah, some people use hemoglobin A1C. Other, so either a fasting blood glucose, you want it to be under 100, or your hemoglobin A1C, you want to be under 5.7.
And you mentioned HDL triglycerides, elevated triglycerides, and lower HDL.
Right.
Should we not look at LDL? And I'm always confused. For years, I've always been confused by all the cholesterol and the LDL, HDL, VLDL markers.
Yeah.
Because our ability to diagnose any of this is not that great, and it seems like we're arguing over what all these numbers mean.
Exactly. That's what it comes down to for me. So you look at LDL cholesterol, and it really is a lousy marker. It is basically a 50-50 shot. And what I mean by that is, when you look at the studies that have been done on patients who come into the hospital with heart attacks, half of them have, elevated cholesterol, and half of them have, normal cholesterol, levels or lower cholesterol levels, and I see the same pattern in the patients that I end up doing heart surgery on. Half of the patients have what are considered, normal cholesterol levels or low enough LDL cholesterol levels. Some of them because they're on medications, some of them just have naturally low LDL cholesterol levels, and yet they're still ending up on the operating room table. So what, again, that tells me is that LDL is a lousy measurement. And we can then go deeper and we can talk about, the ApoB and the particle sizes. And these things do help us refine a little bit better when you know what you're looking at. And again, most physicians, unfortunately, don't understand that. So they're not able to properly interpret those tests. But again, when you look at what can we be doing better, I point to something like a coronary artery calcium scan. This is a simple to do CAT scan. You don't have to put an IV in. It literally takes 5 minutes. You lay down on the table, you get scanned. It's pretty low dose radiation these days, on par with a chest X-ray. And it's going to tell you in its early stages, I have evidence of heart disease or I don't have evidence of heart disease. So to me, that's much more useful information than, maybe this blood marker is putting me at risk for heart disease. And so that's a test that I advocate to be more widely used.
And heart disease is still the number one killer for all of us.
Yeah, heart disease is still the number one killer in the United States and worldwide. It has been that way for the past, here in the U.S., it's been the number one killer since approximately 1960. We really have not been making any headway in our battle against heart disease. So if you look at the, incidence of heart disease, it started to go down some 1980s, 1990s, primarily due to the effects of less people smoking. And then since 2000, it has leveled off. And actually, since 2010, it's been going back up again. And why would that be if, our cholesterol levels are lower? Statins are the most widely prescribed class of medications. People's cholesterols are lower, and yet heart disease is going up. So again, those two facts are incongruent for me and should be for many others.
So diabetes is going up.
Yep, diabetes
obesity is going up. Diabetes is going up, and thus heart disease is going up because it's all related to a carbohydrate rich diet and a low animal fat diet.
Exactly. And we can go even further and add things like Alzheimer's disease to that list. We can add cancer, the number 2 killer. Again, very closely tied to metabolic diseases for many forms of cancer. So, you keep going down the list of all of the, chronic diseases that plague our society. And what is the commonality amongst them? It is metabolic disease. And again, why is that? It's because of the food that we're eating.
I just want to get back to the coronary artery calcium score.
Yep.
is a low score. You don't have heart disease and you don't need to worry, and your diet's fine. And I'm just talking about standard American diet. And there's a higher score. One of those reasons to say, oh, let's get a cath in you, and we got to check it out.
Yeah. So a 0 score means that you don't have any evidence of heart disease. Now, does that mean that everything that you're doing today is perfect? Probably, it's going to depend, honestly. The younger you are, the less meaningful a 0 score is what I tell people. So, yeah, if you're 80 and you have a 0 score, I can pretty confidently tell you you are not going to die of heart disease. If you're 30 and you have a 0 score, that's still an open question. You're probably fine for the next, 3 to 5 years at least, but you need to be keeping an eye on it. And it doesn't mean that you can just be doing, you can't be out there smoking and eating processed food because, this does build over time. If you have a high score and the number that means the number to be concerned about changes as well with your age. But if you have a high score, it may need, depending on how high it is, it may need further investigation like a catheterization, or it may just mean you need to start paying attention to that. You need to start making changes in your diet and lifestyle, and you should be following it over time. This is one of the other mistakes that I see is that people will get the scan the first time. It won't be 0. It will be whatever number it is. And then they just, it doesn't get repeated. Their doctors don't pay attention to it. So I believe that the CAC score is a very powerful tool for us to know if what we're doing is working or not working. Because even if our score isn't 0, let's say you're 50 years old and you get a score of, 150 or 200, which is, elevated, but not horrible. If you make some changes and a couple of years later, you get another scan and your score hasn't changed, hasn't gone up significantly, then you're on the right path. Because if you stay at that level for the rest of your life, yeah, you're not going to have trouble with heart disease. But if it's continually going up, and that's what the average is, we know that when you look at across the population, the average increase in CAC scores is 10 to 20% per year. So if it keeps going up and up and up over time, that's when we get into trouble with heart disease. So 0 scores are reassuring, but like I said, depending what age you are, it's may not be a guarantee, and you still need to be paying attention to these things to make sure that it stays a 0 score.
And the positive and negative predictive value of these tests, I mean, that's some of the nuances of understanding those things, how accurate any test is to predict your odds of getting a disease. Now, besides coronary artery disease, heart disease includes arrhythmias and some other valvular problems and dissections. Yep. Are those also related to inflammation?
So I do think they are. Atrial fibrillation, the most common arrhythmia that we deal with, is clearly related to inflammation. And we see some of these same metabolic factors playing a part in that. We know, for instance, that atrial fibrillation becomes more common as we get older, which is as we're getting more metabolically unhealthy, more common in diabetics, for instance. And I have seen people improve their atrial fibrillation when they, improve their diet, when they eliminate their metabolic disease, their atrial fibrillation in some cases goes away completely, and in some cases is just easier to control. That depends on a number of factors. We look at valvular heart disease. Valvular heart disease, diseases of the valves of the heart, which is the second most common type of operation that I do after, coronary artery bypass to deal with the atherosclerosis. But valvular heart disease, I think, is related to inflammation. What happens to these valves they become inflamed and they become calcified. The same thing that we see happening in our blood vessels. There can be other issues that affect the heart valves, things like infections that, you might on the surface say, well, it's an infection. That's not related to metabolic disease. But on the other side, I can turn it around and say, what makes you prone to the infection? Why does this bacteria, for instance, staph, bacteria that commonly live, that are on our skin all the time, why in some people does that get into their bloodstream and then get onto their heart valves and end up destroying their heart valves? You have to start asking those questions. There's something affecting their immune system. Their defense mechanisms are down. And again, you have to point to metabolic disease. So are these causative? Maybe, maybe not. But I think metabolic disease is certainly contributory to these, to these things. The bottom line for me is that, there's certainly no downside that I have found of improving your metabolic health. So I would bet with whatever medical condition you have, I would start with improve your metabolic health. And, it's probably going to at least improve your overall situation.
And so real quick, what would you say that if someone's going to their doctor, are the sort of 5 tests that your doctor should order for you, or what are the tests that you think are important for people?
Yeah, so I would put a standard cholesterol panel on that list, but I would say, you're paying attention to the HDL cholesterol and the triglycerides, first and foremost from that standard lipid panel. I want to know your blood glucose level, whether you do fasting blood glucose or A1C. I think either one is informative. I want to know your insulin level, your fasting insulin level, because, that relationship between your insulin level and your glucose level, again, tells us whether or not you're insulin sensitive or insulin resistant. And hopefully your doctor can help you figure that out. And again, unfortunately, many doctors just, I don't really ever remember learning much about insulin resistance and how to diagnose it in medical school. I'll be honest, this is all stuff that I have learned afterwards. I have educated myself on, and, I have learned afterwards. So I don't blame the doctors out there. This is a system problem. We don't
for all
get
of us,
educated.
all of us, right? I mean, we've suffered from the same problems we're trying to teach others for.
Exactly.
So there's no chastisation or negativity in this and blaming others.
Exactly. So that would be kind of just the basic panel that I would start most people with. I would probably add, if you're a male, you want to check your testosterone levels, because testosterone levels, again, are a early indicator of metabolic disease. And I think that can be useful to check. And then I would probably add a vitamin D level, because, again, I think vitamin D is very informative about metabolic health.
Let's see, liver disease and metabolic health, do you think they go hand in hand for those that have insulin resistance, metabolic disorders, and seeing liver disease?
Yeah. So again, we know, that fatty liver disease, non-alcoholic fatty liver disease, as it's usually called these days, is becoming the most common cause of liver failure in this country. And even before it gets, way before it gets to the liver failure part of it, it is a very early indicator of metabolic disease. So again, one of the patterns that I see, in patients who are coming to me is, their liver enzymes are going to be mildly increased. They may still be within the normal range of the lab test. And this is another problem we run into, that they're going to have, liver functions, liver enzyme levels that are within the normal lab range, but towards the high end of the normal lab range. And these patients have early fatty liver disease if you look for it correctly. If you do the ultrasound, you do the scan, you look for it correctly. And again, it's an early part of the process. We have very good data to show that that can be reversed. Rob Seifus has done some great work on this. He's a bariatric surgeon, and he puts his patients on metabolically healthy diets, and he does liver biopsies before and after when he's doing these surgical procedures. And he has shown that within a few weeks you can see the fatty liver disease reversing on these diets. So it is something that we should be paying attention to, and unfortunately it's one of those things that we end up missing as a canary in the coal mine again.
My theory is insulin resistance is simply liver damage. And because the bloodstream from the bowels goes to the liver, the pancreatic blood flow goes to the liver. The job of the liver is primarily to convert sugars and amino acids to fat. But as the damage to the liver cells happens, the conversion of those things to fat slows down. And so you ultimately get a rise in your sugar levels. And ultimately, as long as sugar is elevated, insulin is elevated. So insulin is not the cause of disease. It's like obesity. Obesity is not the cause of disease, but the things that got you obese, the things that gave you a high insulin, are actually the cause of disease.
Yeah, I would agree with that. And, I would say, there are so many ways that this manifests. You can look at almost every organ system and you can see, the early effects of this if you're looking for it. And again, I think the thing that's so unfortunate is we miss it over and over and over again. What's so interesting about insulin resistance, about metabolic disease, is here we are, a cardiac surgeon and an OB-GYN, and we're talking about the same disease. The same disease essentially. And you can go specialty by specialty, and you can find, it manifests itself in different ways within each organ system, but it's all the same disease ultimately, and we all miss it. It's really the elephant in the room that just no one pays attention to. We all see it in different ways, but it should all lead us back to the same place.
I've been reading about the glycobiome and glycobiology, and which is something that I never learned ever in medical school or in science studying. And that's what I believe is like the game changer. The glycobiome, the glycans that line every single cell of our body, they're critical to our health, but they're damaged because of our diet, which is damaging the glycobiome. So it makes those microbes and the other inflammatory particles in our bloodstream just go, trying to help us. But we are not helping ourselves because we're consuming a ruminant animal's diet, or an herbivore's or an omnivore's diet, not a carnivore's diet. And it kind of seems so simple. And I think that's what you're really sharing in your book, to stay off of my operating room. And so you've just shared some really great things, but I want to talk about a couple of other things. Fasting. What's your thoughts on fasting?
Yeah, I think fasting can be a very powerful tool for health in general. I think, again, if you are metabolically broken and you're trying to fix that, fasting can be a very powerful tool in the tool belt. But it's got to be used properly. So, what I oftentimes talk to my patients about is, I don't think fasting should necessarily be forced. I think you should end up fasting because you're not hungry. But get to the not being hungry part first. And yeah, some people can kind of force it and they can white knuckle it and they can fast and, probably has some benefits, but it's much more powerful if you just fast because you're simply not hungry. And, honestly, that's what I find myself doing. It will be very common for me that I realized that I just haven't eaten in 24 hours. I've been busy and I've been whatever, and I'm just not, I'm just not hungry, because when I do eat, it is very nutrient dense food, and it keeps me from getting hungry. So, um, you know, in other situations, again, when you're specifically trying to address problems, uh, you know, fasting can be a powerful tool, but it should be used properly.
Do you have a number of meals that you recommend to your clients that they should start with or get to, or does it matter?
Yeah, I think, probably ideal is getting to, depending on your situation, I'm going to say 1 or 2 meals a day. I don't think we were really designed to eat more than twice a day
Yeah, yeah,
when we're eating properly. I think eating 1 meal a day for some people is fine. For others, it's hard to get enough protein and enough nutrients packed into 1 meal. So, that might be pushing it for some people. But really, again, I don't think we were meant to eat more than twice a day. And you don't have to go back that far in history. You go back to your grandparents, your great grandparents, they were probably eating twice a day. They ate in the morning and they ate in the evening, and that was it. That's usually what I'm directing people towards. But again, I don't start by saying only eat twice a day. I usually start by saying, let's get you to be hungry less often, so that you end up only eating once or twice a day.
I'm on my fourth day of a 5-day fast. I typically do one meal a day. I sometimes do one or two snacks, and I kind of practice it. I think it's more sort of a mental, mindful practice, spiritual practice more than anything, which leads me into the mindset. And how do you change the mindset for people?
Yeah. Yeah. So I do agree with you on that. I have done extended fasts as well, and I think their benefit is exactly that. It teaches you, it resets your relationship with the food, because, after you've done a 7-day fast, you realize that, okay, if I have to go 12 hours without eating, no big deal. And most people are going through life that if they've gone 3 hours without eating, it's like panic mode. I see this all around. I have children, who are at school age, and it just amazes me how, like, all the messaging in school, like, make sure you bring snacks, and if like, if these kids go more than 3 hours without eating, they're gonna, be dropping dead. And
Yeah.
it just, that's been ingrained in us again. I do agree with you that the extended fasting is powerful for that. The mindset in general, I think, is very, very important part of this. And the way that I like to um, coach people on that is that you need to be, the way I phrase it in the book is that you want to be thinking of your health as a system, not as a goal. You want to be keeping the big picture in mind. What do I want to accomplish? But not those short-term goals that we just get too hung up on today. We talk about, I want to lose 20 pounds, and that doesn't serve you, because one of two things happens when you focus on a short-term goal. Um, you make changes and you accomplish the goal, you lose the 20 pounds, and you say, great, I did what I wanted to do, and now I'm going to go back to what I was doing before. Or you make the changes, you don't lose the 20 pounds, you get discouraged, and you say, I might as well go back to what I was doing before. So we really need to be thinking bigger picture, longer time frames. You have to be telling yourself, I want to be healthy. I want to be metabolically healthy, and I need to find the habits that are going to support my metabolic health.
Is it in the coach and the constant listening and learning these new habits? How important is that?
I think it's very important. I think if this isn't becoming part of your daily mindset and your daily practice, you're not going to sustain it. It's like anything else. We if you're not paying attention to it, it's typically not going to improve on its own. And especially when we're talking about your health, because again, you look all around you, you look at, essentially everyone around you is sick. So if you're not intentionally doing something different, you're going to end up the same. We're all human beings. So there's no reason to think that, I can be doing what everyone else around me is doing and I can get different results from that.
So we've got fasting mindset, and what's your thoughts on exercise and how important it is to move?
Yeah, so movement more than exercise is what I say. Just get more activity throughout your day. And the priority around there, again, should be what can I do to build and maintain muscle? Because again, the data is very clear that the better you're able to build and maintain muscle as you age, the longer you're going to live and the better you're going to live, the better quality of life you're going to have. So I prioritize building and maintaining muscle, and incorporating the activities that are going to do that. And again, that doesn't mean you have to go to the gym and lift weights. You just have to do, resistance exercise, which is moving your body basically. Walking is a resistance exercise. You can do simple things at home, if you want, like push-ups and pull-ups, squats, body weight squats. These are very powerful. But again, we have lots of data, lots of studies showing a simple thing like a 10 to 15 minute walk after you eat can be very powerful for your metabolic health.
So we're sitting around and you're standing in the operating room all day, and you get home, and I'm sure probably your standard, like mine, was you come home, you might have dinner, you watch the news before or after, and you kind of sit around, you watch TV. And what you're saying is we gotta move, because our ancestors, they moved, and they didn't lift weights, did they?
No, they, you could say that, whatever they were doing to survive was probably somewhat physically demanding at times. But yeah, you're right. We didn't, again, prior to the, 1950s, like no one went to gyms, there were, you really didn't have people exercising per se. They were too busy living their life. And the gym craze of the 1970s, 1980s, 1990s, and now today, there's a gym on every corner, yet we're unhealthier.
Yeah.
So obviously it isn't having the intended effect. And I tell people, if you like it, if you want to do it, great. But when you're at the gym, if you're going to be at the gym, prioritize building muscle. And then if you want to do some cardio, have at it. I think it has mental health benefits for many people. I just think it's, most of the people that I deal with, I have a lot of clients who are busy professionals, entrepreneurs, and so time is their most precious resource. And I just don't think that the time, spending an hour or two on the treadmill a day is not a worthwhile investment of your time for the most part.
I would say that if you're exercising most of the time, you're not being creative in much else.
Yeah, exactly. It's a lost opportunity. I always think about opportunity cost. What are you passing on? What are you giving up by, spending the time doing that? And you're right. For most people, there are better things that they could be doing. And, again, so just get more active during your day. Take the walk every hour. Use a stand-up desk instead of sitting down if you have a desk if you have a desk job. Park further away when you're, at the market, at the mall, at work, whatever it is. Use the stairs instead of the elevator. Simple things like this can really have a powerful impact. And people, again, people don't realize that. That's gotten lost in the marketing sort of around gyms and exercise. They've lost the fact that, you can just be more active during your day, and that's going to have powerful impact.
Do you think part of the problem as a physician for us that our training is simply diagnosis and then treatment of the disease? We never focused on the cause, and it's sort of like just a revolving door in essence in our day job, where we don't really get a chance to sit with people and talk to people and know them. And then we're not trained to be coaches and cheerleaders. It's like combat medicine. It's almost like emergency medicine in a sense in our regular office practices. And what are your thoughts on how we can really sort of work to change that and inspire more doctors to be coaches and cheerleaders like yourself?
Yeah, exactly. So, and I very much admit that, that's how I was. I mean, I spent the first, 15 years of my career as a cardiac surgeon doing exactly that. There was always another patient to operate on. And they came to me, I made the diagnosis, I delivered the treatment, and I moved on to the next one. And I really didn't think about, why are there so many patients? What is causing this? But once my eyes were opened, I knew I couldn't continue in that model. So I have very much changed the way that I practice medicine. And I believe, my fellow physicians, my colleagues should be doing the same, because it's better for the patient and it's better for the doctor. I am much more satisfied with the way I practice medicine, that I take the time now to talk to that patient about why they ended up on my operating table, how the operation that I'm doing isn't going to address that root cause. Yes, it's going to, extend your life or improve your life, but it's not addressing the root cause. And if we don't address the root cause, it's still going to be a problem in your life. And then on the other side of things, I also run a telemedicine practice where I help people, to prevent heart disease, to not end up on my operating table. Again, very satisfying to see these people who were headed down the path. They were going to be there and were able to change direction and change their habits, meaningfully impact their lives, and they then impact the lives of those around them. And that's what's really powerful about this, because, I might be talking to that mother and treating her, but I know in the back of my mind that this is now going to help her children as well. And that's what's really powerful about it.
So in your practice today, because you're also a cardiothoracic surgeon, doing immense work, and you're part-time, full-time, and the number of hours you work, I know, are probably still the same as most full-time people's work. And how do you incorporate that in your telehealth work, and what's your sort of ultimate goal and dream in all of this?
Yeah. So, the way that my life is currently structured, so I do travel work, what's called locums work for my cardiothoracic surgical work. So there is a shortage of cardiothoracic surgeons in this country. In other words, there aren't enough surgeons to do all the heart surgery that needs to be done. And that should be that should be causing alarm bells to go off everywhere, but it's not. It's just accepted. So, so I travel to places, that are short on cardiac surgeons. And I do that, as you said, sort of on a, part-time basis, but, the hours are still long and there's still high demand for those services. I then run my telemedicine practice as well, where, like I said, I work one-on-one with people to help them prevent the need for heart surgery. And, I view that as all part of a bigger picture. Ultimately, I think the guys like you and I who have been enlightened to this, our mission is to spread that word. And it's to spread the word to to the patients, the people who need to hear it, but also to spread the word to our fellow physicians. Because I think if more and more of our fellow physicians wake up to this, and we actually start addressing the root causes of this disease, of these diseases, we end up with less sick people. And that solves the problem of not being enough doctors and not being enough resources to go around. The problem isn't that we don't have enough doctors. The problem is that we have too many sick people. And we really need to start addressing that problem.
The number of sick people is growing and outpacing the number of doctors that are trained to take care of the people that are sick. And the cost of healthcare is getting out of control. And
it's, I think that's the primary driver behind doctors getting burnt out these days, is that, they're getting frustrated because they're not actually improving people, and most doctors don't recognize that. They're trying to do great work. They do great work, but they're not meaningfully impacting their patients because they're not addressing the root cause problems. And again, I don't blame the individual physicians. This is the way we're educated, and this is the way the whole medical system is constructed, on treating the problems, not curing the problems, not addressing the root causes.
So as a client of yours, I'm a patient, and I call you, and I'm feeling pretty good, but I'm a standard eater, and I want to lose a few pounds. I'm a type A worker. What's sort of just a general sense of your protocol that you'd put me on?
Yeah, so it's the first step is figuring out where you are from a metabolic health standpoint, doing a good assessment, the testing we talked about, and then starting to make the changes. And first and foremost in my mind is what you are eating, but it does go beyond that. We need to address, how are you sleeping? We need to address the activity that you're getting or not getting. We need to address how you're dealing with the stress in your life. Stress is so interesting because we don't have a great way of quantifying it. You can't measure it. There's no blood test really that shows you someone is stressed. But it's a very important factor. I mean, it's well described, that stress can directly lead to heart disease. So it's very interesting. And what I talk to people about is you need to be managing your stress in some way. We all have busy, stressful lives. You can't eliminate that. You can't just go hide on some, desert on some island somewhere, because that's going to have its own stress associated with it. But, you just have to find a way to process and unload that stress. And that can be many different things. Some people it's meditation, some people it's religion, some people it's their community, having a good family, whatever it is for you, you just need to find that thing that can help you process and offload that stress. But I think these all play together, and they all affect each other in many ways. For instance, we know, if you're high stress, you're not sleeping well. If you don't sleep well, you tend to not eat well, and it all becomes, one vicious cycle. So you got to just start from where you're at and start improving.
Stress is kind of nature, especially in the medical field, for sure. So there are many things that we need to help so many of our physician friends, colleagues in all of this. So my plan is to stay off of your operating table. And where can people find your book, and where can they find you, Dr. Ovadia?
Yeah, sure thing. So stay off my operating table. The book, it's widely available, all the usual online places. The best place to start with me is at ifixhearts.com. Has information. It has, the book, the courses, the educational materials that I have available. I have the coaching programs, and I have the private medical practice. And again, you can find all of that at ifixhearts.com. And if you're on social media, the best place to find me is at Twitter, again, at ifixhearts on Twitter as well.
Is there anything that I may not have asked or you wanted to make sure that we shared in our talk today?
No, I think this was a great discussion, fascinating discussion. Great follow up for the time we spent together in Costa Rica, which was amazing. I just think it's interactions like that. It's really doctors interacting with doctors and trying to help our colleagues to find their way out of this mess is where we can best be serving our mission.
The reversed TV series is coming out sometime this year. We don't know when, but the Carnivore series and a great, amazing group of people. And let's see, I'm in Sarasota sometimes. You're in Tampa, is that right? Sometimes.
Yeah, Tampa, St. Pete. Yeah.
Yeah. So we'll have to make sure we get a meetup down there. But bringing colleagues together, but just everyone to listen and learn and have the conversation, because that's the way we're going to grow this health initiative. I call it social medicine, which is taking medicine out of the doctor's office and putting it available to everyone. Because you and I, when we went to medical school, you had to go to medical school, go to the library. Access to this stuff there wasn't online.
Right, exactly.
Well, really a pleasure. I look forward to us meeting again soon. And I think we're going to talk on your channel sometime soon. And I look forward to it because this is so important that everyone can listen and learn in ideas that are radically different. So thank you so much.
Thank you, Rob.
Appreciate you. So thanks everyone for joining us.